Hello and welcome to my ophthalmic teacher, and this is the second part of the anatomy and action of extraocular muscles. And today we're going to talk about the mechanism of action of these muscles. So there are two types of ocular movements, monocular and binocular. The monocular movements are known as ductions, and they consist of adduction, abduction, elevation, depression, intorsion and extorsion. How do we test these movements? By occluding the fellow eye and asking the patient to follow a target in each direction of gaze. Then we have the binocular movements, which are of two types, versions and vergences. Vergens are conjugate movements, that is, both eyes move together in the same direction, right? For example, levoversion, both eyes moving to the left, dextroversion, both eyes moving to the right, and so on. Vergences are also binocular movements, but the eyes are now moving in disconjugate or opposite directions. For example, convergence, both eyes are moving inside. Divergence, both eyes are moving outside. Okay, so that's the type of ocular movements. Now there are 6 cardinal position of gaze. Now by cardinal position we mean that each of the 12 extraocular muscles can be tested individually in their main field of action. Okay, it's in an H shaped. Okay, so for example, let's take the left eye. Now adduction is by the medial rectus, so that's the cardinal position, okay, for the medial rectus. Elevation in adduction, inferior oblique. Depression in adduction, superior oblique. We've already seen that in the previous lecture. Abduction is bilateral rectus. Elevation in abduction is superior rectus, which is also the best position for testing the action of superior rectus. Depression in abduction is inferior rectus, right? Now, those were the 6 cardinal positions. These are the 9 diagnostic positions in which 2 more have been added, the elevation and the depression, right? So that becomes 9 diagnostic position of gaze. Now, in the previous class, we discussed the anatomy and the action. Now, let's watch a short video of the action of the, superior rectus and the inferior rectus and the oblique muscles, because they are slightly complicated when compared to the horizontal recti. So that's your superior rectus over there, okay? And the orbital axis, the line of axis of the muscle. Now suppose the eye is abducted by 23 degrees. The muscle here is acting as a pure elevator. That is why superiors are pure elevator or depressor in the abducted. See how the eye is elevating? Because the muscle is in line with the orbital axis, right? In the abducted position. Similarly, for the inferior rectus, depression is going to happen because the inferior rectus is in line with the orbital axis. What happens if the eye is adducted? That is pointing inwards. Now the superior rectus is at 90 degrees to the orbital axis. This is the orbital axis. So a rotational movement would happen. And since it is the superior rectus, it is on the top of the globe, so it will intort, right? Similarly, inferior rectus is at the bottom of the globe and it will extort. Look at the angle, 90 degrees. Now this is the oblique, okay? Superior oblique. So it's already making an angle of 51 degrees with the orbital axis in the primary position. Now suppose the eye is adducted or rotated inwards. The axes are coinciding. In this action, only one dimensional single dimension movement will be there, and that is depression for the superior oblique. See, it's pulling the eyeball like that. Okay, so depression in case of superior oblique. Why? Because the line of pull of the muscle, which is this way, is parallel to the orbital axis, which is this way in case of the adducted eye. So superior oblique, depression. Similarly, inferior oblique. Okay, let's talk about the intorsion first. So now what happens when the eye is abducted? It is now at 90 degrees. The muscle is at 90 degrees to the orbital axis. So pure intorsion. So pure intorter in abduction, right? The tertiary action of both the obliques are abduction. Okay, that's because of the arrangement of the muscle. Now this is the inferior oblique. And adducted eye. So it is acting as a pure elevator in the adducted eye. Only depression and elevation happening in the adducted eye for the obliques, right? Because the line of action of muscle is in line with the orbital axis of the adducted eye. So again, that's the inferior oblique, and the eye is now abducted. And since the muscle is attached to the bottom of the globe, it's going to cause extorsion or outward rotation of the eyeball or of the nasal limbus to be specific. So that's your inferior oblique muscle for you. And again, this muscle also causes abduction. Now, both the obliques, their tertiary action is abduction. That is because of the direction of the fibers, as you can see in the clip. Moving on. Now, these are again the 9 diagnostic positions, right? 9 diagnostic positions. This one in blue, this is the primary position labeled as 1. The ones labeled as 2, these are secondary positions of the eyeball. Okay, I'm talking about the positions of the eyeball, remember, not the actions of the muscles. So these are secondary positions of the eyeball, and these are the tertiary positions of the eyeball. Okay, so there are primary, secondary, tertiary positions of the eyeball also, as denoted here. Then what are the cardinal position? This is the cardinal position, right, in which each muscle is isolated and tested. Cardinal positions. And this is the midline vertical. That's okay. That's even if you don't remember, nothing special about that. So 6 cardinal, 9 diagnostic positions, and the center one is the primary position, right? So elevation. Now elevation is brought about by the elevators. Which are the elevators? The superior recti, of course. And which is the other elevator? Inferior oblique, as we saw in the secondary actions. Similarly, which one is the depressor? Inferior rectus, we know that. And superior oblique in the secondary action, right? Again, elevators in the abducted position, superior rectus, and again, inferior oblique. Elevation is happening, no? So it is abducted for the right eye, so superior rectus, and elevator in the adducted in the left eye is inferior oblique. Similarly, depression in abduction, inferior rectus, depression in adduction, superior oblique. Again, elevation in abduction, superior rectus, elevation in adduction, inferior oblique. And similarly for depression in abduction, inferior rectus, depression in adduction, superior oblique, right? So if you've understood this diagram, then you can just, keep revising it from time to time, and you can, diagnose the paralyzed muscle very easily. Okay. So now this one's very easy. Look at the primary position. The primary position itself is telling you the diagnosis. The right eye is adducted, right? So some muscle is overacting here. The medial rectus, of course, is overacting. So if the medial rectus is overacting, which is the paralyzed muscle, the lateral rectus. And look at the dextroversion, that is in the right gaze. This is not moving to the right. Okay, so abduction is not happening in the right eye. So the right lateral rectus is paralyzed, right? So just with the help of these 3 figures, 1, 2, and 3, you're able to, pinpoint the diagnosis. So this is right lateral rectus palsy. Now this is a little more trickier. So what is it? What do you see in the primary position? You see that the right eye is hypertropic. It is upwards, right? So hypertropia in primary position, that could be because of overaction of the elevators or underaction of the depressors. So we ask the patient to elevate and depress. Elevation seems all right. Both the lower limbus are at the same level. So elevation seems fine. Depression. Now, in the right eye, the depression is limited. Okay. So right eye depressors, inferior rectus, the right inferior rectus, and right superior oblique. So the depressors in the right eye are at a problem, are problematic, right? Now, let us look at this one. We have to find out whether the right inferior rectus or the right superior oblique is involved. How do we find that out? What is the function of inferior rectus? Depression. So this photo is not helping us anymore. What is the secondary action of superior oblique? Depression in adduction. Now look at this. The right eye is in adduction and it should be depressing because this is a picture. This is a what gaze position is this? This is levodepression, right? So both the eyes should be depressing while looking to the left. This one's fine, but this one's not depressing. It is not the inferior rectus that is responsible for this movement, but superior oblique. So limited depression in adduction is a function of defective superior oblique. So for the right eye, it is the superior oblique muscle. One more thing, if the superior oblique is underacting, the inferior oblique in the ipsilateral eye would be overacting. It is the antagonist. So look at this diagram. Now here, the person is looking to the left, okay? Simple levoversion is happening. But this eye is going on elevating. Now what is the elevator of this eye in levoversion? Which muscle is which muscle performs elevation as a secondary action? It is the inferior oblique. So this is right inferior oblique overaction happening as a result of right superior oblique underaction, right? So this is a case of right superior oblique palsy and right inferior oblique overaction. So how to document the movements? This is how you document. Okay, these are the cardinal positions, right? And the grading is in the form of -4, -3, -2, -1, 0, +1, +2, depending on whether there is underaction and overaction. So this is the diagram that you draw, okay, for depicting the action on paper. And I think these movements we have already seen, the cardinal position. And okay, two very important laws that you have to remember, the Herring's law and the Sherrington's law. Herring law states that equal and simultaneous innervation goes to a pair of yoke muscles. Yoke muscles are basically synergistic muscles which contract simultaneously in conjugate binocular movements. For example, in levoversion, the lateral rectus of the left eye and the medial rectus of the right eye receive an equal and simultaneous flow of innervation. Okay, equal and simultaneous innervation to a pair of synergistic muscles in each eye. Okay, that is Herring's law of equal innervation. Sherrington law of reciprocal innervation. So for the same eye, when initiating a movement, stimulation of a muscle is accompanied by simultaneous inhibition of its antagonist in the same eye. Okay, obviously that has so as to enable the movement. For example, if the left eye is adducting, the left medial rectus is stimulated, but the lateral rectus has to be relaxed. So inhibitory flow goes to the lateral rectus. So that is the Sherrington law of reciprocal innervation for the agonist pair of the same eye, and Herring law of equal innervation is for the synergistic pair of the two eyes. And lastly, this is important. Just remember the neural control of all these extraocular muscles is in the brain stem. Okay, so that's basically your midbrain pons and medulla. So the third nerve nucleus is in the midbrain. The third nerve supplies all the muscles except superior rectus, superior oblique, and lateral rectus. So superior oblique is supplied by the fourth one. The fourth one is also located over here, and the sixth one is also located here. So this is the pons. Okay, and remember for your MCQs, the Center for Conjugate Lateral Gaze, that is horizontal movements. For example, saccades. This is your PPRF over here, okay? So remember this PPRF is the horizontal gaze center. And the brainstem is the site of the nuclei of all these cranial nerves which supply the extraocular muscles. So that's it for the mechanism of action of extraocular muscles. And I hope this lecture helped you. And you can go back and revise on the YouTube channel, My Opthal Teacher. And thank you for listening.